Yeah, so very good morning all. The topic which I have is simple but yet not so simple. It is on ocular hypertension. When should treatment be started? No financial disclosures or conflicts of interest. What is ocular hypertension? Most of us know that elevated IOP in the absence of clinically detectable optic nerve or visual field changes. So OHT is not glaucoma, but OHT, of course, it has got a high risk of glaucoma. Why treatment criteria is important in OHT? Because not all ocular hypertensives develop glaucoma. Lifetime treatment implications are there, cost and adherence issues with medication, as Vinita madam has rightly told. Psychological labeling of glaucoma patient that is not desirable. So we need to treat all or only high-risk eyes. The danger is treating everyone, treating no one, or pretending that both are safe. So either of this should not be done. This is a study, OATS, which we rely on for our treatment. 5-year conversion rate in this was found to be 9.5% in untreated eyes. Conversion means from OHT to POG. And in treated eyes, the conversion was found to be 4.4%. Now, this was a good study with a good sample size, 1637, minimum limitations. 50% relative risk reduction was found in those OHTs where treatment was started. Absolute risk reduction was modest. Most OHT patients do not convert to POAG in 5 years. So this was what was found from this study, unless patient is having some high risk criteria. So what are these high risk factors for conversion? Higher baseline IOP, older age, thin CCT. CCT was found to be a very important predictor for conversion to POAG in OAT study. Large CDR, higher PSD on visual fields. Then there were some additional factors identified in univariate analysis. African American origin, male gender, heart disease. Low risk case, we need to observe. High risk, we need to treat. So what are the low risk cases? IOP less than 24, thick cornea more than 580, young patient, small cup, no family history. In these we can observe. Start treatment if estimated 5-year risk is more than 15%. So how do we calculate this risk? There are tables. Online there are many tables available. IOP persistently, if it is more than 28 to 30, progressive disc damage is found, multiple major risk factors and poor follow-up reliability is there, then we need to start treatment and to not rush if the case is opposite, like low 5-year risk, stable imaging, and there is reliable follow-up. This is just one of the table, that OATS 5-year risk point table. In this age, mean IOP, CCT, vertical CDR, PSD, all these points are put, and total points, the risk that's calculated as such. So risk category, if it is less than 2.5%, the risk category is low. If it is 6 to 9, then below 5%, 10 to 12, it is 10% moderate, and higher than this 12 or 15%, we say it is high risk category. We did not go into all this and add the figures up, but rather there are online risk criteria, online risk formulas available, which we can use. There are some special situations in ocular hypertensives, young patients with high IOP, elderly with mild elevation, monocular patient, family history of blindness, steroid responders. So in all these cases, and maybe some more, we need to value clinical judgment more than the standard protocol, as we do in most cases of glaucoma. What target should we set? OATS aimed for 20% IOP reduction from baseline, target IOP less than 24 millimeter, customized target based on life expectancy, baseline risk, and patient preference. Now let's go through some cases fast. So 45-year female, right eye 26, left eye 28, both eye CCT 580, CDR, it's around 0.7. Normal perimetry and OCT, no family history. What we need to do, most of us, it's a straightforward case. So this is thick cornea. So general ophthalmologists, sometimes they rely a lot on this pressures, 26, 28, arre baapre, we need to start treatment. So we need to also do CCT. It's thick cornea and true IOP likely overestimated. Rest of the features are, they look perfectly normal. Like this looks like more like physiological cupping. It is bilaterally symmetrical. There are no additional risk factors, so we can observe this case with periodic follow-up. 63-year male, right eye 30, left eye 28, CCT 530, CDR is same 0.7, but we can find that the disc here is not that physiological. Maybe there are some changes in the disc. Borderline PSD, and the patient is hypertensive. So age is more than 60, high baseline IOP, suspicious disc. Decision will be to treat, target 20 to 25% IOP reduction with close monitoring. Teaching point is if there are risk factors, we need to start treatment. 35-year male, IOP 32 to 34, CCT 540, CDR 0.4, normal perimetry and OCT. So here things are normal. CDR is 0.4, normal perimetry and OCT, but the IOP is very high. CCT is almost normal and IOP is very high. Long life expectancy because the patient is young and risk accumulates over decades. So the decision may vary, but some of us can decide to treat even if disc and imaging normal. Teaching point is if IOP more than 30, it is usually treatment territory. So step 1 in treatment of OHT, IOP if it is more than 21, we need to confirm open angles, normal disc, normal visual field, no secondary cause. And if everything is normal, IOP is more, then it is of course OHT, that's diagnosis. Step 2 is assess the risk factors, age, IOP, CCT, CDR, suspicious PSD, family history, poor follow-up. Step 3 is estimate the 5-year risk, low, moderate and high, and treat regardless of risk if IOP is more than 30, as we saw in the last case, progressive disc damage, monoocular patient, strong family history. In these cases, we need to start early treatment. So, to sum up, in ocular hypertension, hesitation can blind, but so can haste. And I will conclude with the quote that the hardest decision in glaucoma is not how to treat, but when not to. Thank you, AIOS and the chief instructor for giving me this opportunity.
Thank you, Dr. Lippi. Any question?
I want to add one thing that the single IOP reading by NCT is not ocular hypertension. And if you say patient that you have a glaucoma, the patient become anxious. There's a psyche related to this disease because as soon as you say it is a glaucoma, they will go and do the Google and then they think that they are going to become a blind. So there are so many patients in which the medication has been started just because of a single reading of NCT. So we should not be in a hurry to start the treatment, confirm the diagnosis and then you can start the treatment.
So Lippi, in one of your patients, you didn't do OCT. The fields were showing some learning defects, the pressures were borderline. So is it important to do OCT in patients with ocular hypertension in all patients, and what is the importance?
Yeah, it's of course important because we all know that functional changes and structural changes, there is a gap between them. So first when I was in fellowship, there were other modalities available, HRT, GDX, but now we know that OCT has taken over those modalities. So of course we need to do good OCT. Good OCT means we need to check the parameters, the patient position and everything, and do a follow-up with OCT preferably rather than just the fields. So yes, madam, OCT is important.
There is always a question, will you start treatment on the basis of OCT?
It's of course, yeah, it's of course a combined clinical judgment which we need to have.
Factors like if the pressure is high, this is suspicious, OCT changes are there. So you have to rule out pre-perimetric glaucoma and you can start if there is family history and all.
Yes.
I think this is the one entity where you rely more on OCT changes. So when for the progression of the disease, probably if you see the progression on the OCT, you will not wait in ocular hypertensive because now we are thinking that patient is going to develop into a glaucoma. So you may be starting the treatment only on the OCT basis and you may not wait for the field damage to occur because we all know the field damage will come later. So now, please.
Yeah, so as I just commented that a clinical judgment, a complete clinical judgment. So we do take diurnal variation also into account along with family history, as madam told, thin cornea, so all these factors should be taken into account. Diurnal, it is not many a time possible that 2-hour reading is not possible, but we can bridge it so that morning, evening, early morning, all these are covered and we can do diurnal if it is feasible.
So now